We need to talk a little bit more about contrast media and some of the specifics and the whys of why we use what we use. So we'll start with iodinated contrast media, which is really our second choice. For the most part, we want to use barium for a number of different reasons. But there are some benefits to using the iodinated contrast. One is that it does move through the GI system a little bit faster. A lot faster, really, because it has a laxative effect. So a laxative, tends to draw moisture into the gastrointestinal system, especially in the colon. So it has a tendency to draw moisture into the, into the lumen to flush everything out, right? So it has a tendency to clear a whole lot faster than what barium does. And what you'll see sometimes is that I've worked with some techs who, if they were doing an upper GI, they would take some of the iodinated contrast and mix in with the barium to take advantage of that laxative effect to try to make it move through a little bit faster. Whether or not that actually helped, I don't know, but if you're going to do that, it's very important that you ask the patient beforehand if they're allergic to iodine. So when we get into myelography and use the contrast that we use in myelography, the sensitivity to iodine is less important than what it is here. So you want to ask the patient if they're allergic to iodine before you do anything like that. It's probably best just not to, but if you happen to see somebody do it, that's what the effect that they're trying to get to is a faster exam using barium. So the problem with iodinated contrast, in addition to the potential allergic reaction, is that it does not adhere to the mucosa well. So it'll show whether or not it passes, but it doesn't line the mucosa very well. So think of it kind of like, let's say drinking a tea, having a little bit of tea in a glass and rotating it around, like this. How well does, get that on there, how well does the water adhere to the cup? It doesn't. It doesn't at all, right? I mean, I can reach in there and I didn't even bring any moisture out of that, right? So if this was a milkshake though, how well would the milkshake adhere?
Better.
Very much better, right? Even if it was completely melted, if it was room temperature, you'd still have some line in it, right? So think of barium as kind of like a milkshake as opposed to the iodinated being more like water. It just doesn't adhere real well. So if we need to see the mucosal lining, then the iodinated contrast is just not going to give it to us, right? So if we're looking for polyps or something like that, it's going to be much harder to see that with the iodinated contrast. You can definitely tell whether or not the patient's got a bowel obstruction, but you're just not going to see that mucosa very well. So in that, it is diagnostic, but it's not ideal, right? So it provides satisfactory examination of stomach, duodenum, small intestine, but not so much for the mucosal lining. And when we use air contrast, that's specifically what we're looking for, is that what we'll do is we'll put the contrast into the patient, the barium into the patient. We might take some of that barium back out, like if we're doing a barium enema, we might fill the patient up, evacuate some of that, and then put the air into the patient. Have the patient roll around, then put the air into the patient so that we can see that mucosal lining really, really well. Since the iodinated doesn't adhere to the mucosal lining, it doesn't matter how much air we put into the patient, we're just making them more uncomfortable, right? So we can't do air contrast with iodinated contrast, only barium. So anytime on a test question you're looking at air contrast, you're looking at one type of barium, or I gotta stop giving an answer, one type of contrast, positive contrast, and that is barium, right? So there's that. So, but like I mentioned before, if they're probably going to surgery for whatever reason, if it's a bowel obstruction or whatever else, we prefer to use iodinated contrast because it can be removed easily. And also, if there's a perforation, then it just, the body absorbs it and gets rid of it. So there's only one time in my entire career that we ever intentionally used barium on a patient who had a bleed. And that was a patient that she had been to surgery. She was very, very much geriatric patient. She was, 80, 90 years old or so. And they couldn't find or stop her bleed. And so an old treatment that they used to use a long, long time ago was to use extremely thick barium in hopes that the barium would kind of, you know what the stuff is that you put in a flat tire that inflates the flat and then it's seal flat, right? They kind of use it like that. So they would put really, really thick barium into the patient, hoping that the barium would settle in the perforation and seal it up. And so they abandoned that procedure like decades and decades ago. They don't do that anymore. But this one doctor was so desperate to stop the bleed on this patient that he actually tried it. So one time in my entire career did we ever use barium on a patient with a bleed. Every other patient, even for suspected bleed, was iodinated contrast. So let's see, pretty much all the same thing. So preparation of the room, adjust the equipment controls, make sure that you reset your backup timer if your machine requires that. Make sure that you're shooting for, with high kVp for solid barium. It's going to be a little bit lower for air contrast. It's going to be similar to what iodinated contrast is going to be. Make sure that you have the footboard and shoulder supports if your machine comes equipped with shoulder supports on them. Then test them, all right? So we already talked about the modified barium swallow. There is a time to take the footboard off of your fluoro machine. So some of these GI exams, you're going to start with the patient upright, okay? And your patients are sick or they wouldn't be there. Most of your patients are going to be elderly, all right? So hip fractures are a common thing with older patients. So the way the footboard locks in on most of your machines is that there's a slot on both sides of the rail, and there's a projection on the footboard that you squeeze the handles on the footboard, you put it onto the table, and you slide the footboard until you hear that loud clack. Anybody taken off and put on the footboard, then you know what I'm talking about, right? Well, sometimes one side will lock in and one side won't. And the problem with that is that it will hold well enough to stand the machine up, but if there's any weight placed on it, it might cock that thing a little bit, and then the whole thing comes sliding down. So that footboard is going to be about a foot off the ground, right, with the table as low as it'll go. And so you put a fragile old patient on that, and then you put them in free fall for a foot, and you got a problem, right? So make sure that it's locked in on both sides, and when I say pull hard, I mean grab that thing, lock it in, hear the clack, grab it, and try to tear it off of the machine to make sure it's locked in well, okay? Because the last thing you want is to have the patient to fall because you didn't lock the footboard in real well. So number of IRs available, really, that should come out of this PowerPoint presentation. That was whenever we use screens, films, CR, whatever. So, but the rest of it's still applicable. Prepare the type of contrast that you're going to use. Know the exam type. For upper GI, you're going to use a thicker barium. If you're doing a small bowel follow-through, you're probably going to use a thicker for the upper GI portion and a thinner for the small bowel follow-through, all right? So make sure that you know what kind of exam you're doing and have the appropriate contrast. If you're doing an upper GI, it's going to be double contrast if it's not iodinated. So if you know that the patient has a bleed, you're going to have iodinated contrast, right? But if they don't and you're doing an upper GI, assume that it's going to be air contrast. So the barium provides one contrast and air provides the other. And what that is those CO2 packets. So it's basically an unflavored Alka-Seltzer, crushed up. So you have just a little bit of water, just a small amount of water, and then have those things off to the side. So, the doc may have a patient drink a little bit of barium, and they'll say, give me the fizzies or whatever. So at that point, you pour the CO2 into the water, hand it to the patient drinks it. Tell the patient to drink it right away, because sometimes the patient will look at it and they want it to stop fizzing. Well, we need it to go down and fizz, because that introduces the air so that we get the air contrast. If we're doing air contrast, we're looking for the air, well, no, not air fluid levels in this case. Mucosal lining, okay? Air contrast, mucosal lining. All right, just lock those two together. Air contrast is always mucosal lining. And then make sure that you have the appropriate markers available, and it's going to be kind of site specific. And what I mean by that is that they may have you put a marker on there that indicates upright. They may have you put a marker on there that indicates upper GI, something like that. So make sure you have those available. They may have you put a marker on there if you're doing small bowel follow through that indicates which image it was, 15 minute, 30 minute, 45 minutes, something like that. So make sure you have all those available as well. Same things, towels, make sure that you've got something for the patient to throw up in if it comes to that, cold wet wash rag, all the stuff. So preparation of the patient. Try to make the conversation with the patient and the description of the exam that you're going to do conversational, right? Don't get overly specific with the patient, and this applies to pretty much every exam that you're going to do, and if you get overly specific and overly technical, the patient has no idea what you're talking about, especially if it's an older patient. So try to make it relatable to them. We're going to have you drink some stuff. It tastes terrible, but it's important that you drink it as fast as you can so that we get a good study. You go in and say, we're going to give you some orographin, and start describing and naming names of the contrast type, and you're going to lose your patient, right? So just make it as conversational as possible, and be honest about it. Tell them it's going to taste terrible, because if you say it's not all that bad and they drink it, what are you instantly?
A liar.
A liar, right? And they don't trust anything else you're going to say, right? So tell them it's going to be bad, but you need them to drink it as quickly as possible. The faster they drink it, the quicker they get it over with. Okay? So explain the administration, tell them how it's going to go inside of them. We have exam types for the upper GI that we actually put it through a tube in the nose. So most of the time it's just going to be drink, but sometimes there's that. Then tell them what to expect during the exam and after the exam. Barium comes out looking identical to what it went in looking like. Okay, so for at least a day, yeah, exactly. At least a day, it's going to look like dried dog poo. The way it turns white, it's just going to look like that. Okay, so don't use those words, but just tell them it's going to come out looking like it went in, and they'll know what you're talking about. So also though, we have two things here. We tend to stress one and not the other. So what's the purpose of the colon? Is to transport waste, but what's the other thing?
To absorb nutrients.
Reabsorb water specifically, right? So your patients are going to come to you NPO, so they're going to be a little bit dehydrated. The older the patient is, the more dehydrated they're going to be, right? So you're going to give them barium. And what's the purpose of the colon? Get rid of waste, absorb water. So if they're dehydrated, what's going to happen to the barium? That is exactly what's going to happen is it's going to suck the water out of the barium, and now they're constipated, right? So what do you need to tell the patient post-procedure?
Drink a lot of water.
Drink a lot of water, right? So we tend to stress that on barium exams, but what about iodinated? Well, they're coming to us dehydrated, and what are we going to give them?
Contrast.
A contrast that acts as a laxative. So how are you going to send them away from you? Even more dehydrated, right? So I'm telling you what you need to do is you need to tell both of those patient types push water for the next 24 hours. One is to rehydrate, one is to keep, you know, the patient from getting constipated. So explain the procedure, explain what, you know, they need to do post-procedure, introduce the patient to whoever it is that's going to be doing the exam. Motion artifact, we already talked about that. Peristalsis is going to be affected by body habitus, pathology, pain medicine, pain itself, right? So how many moms in the room? None. Okay, so this is good. This is good. So when you're in childbirth, you go through the contractions, you got a lot of pain going on, right? Your bowel will seize up. Okay, it's what we refer to as a non-obstruct ileus. So you've not only got the back pain from the labor, but you're suddenly going to have abdominal pain because your bowel just stops, right? So that's a non-obstruct ileus. Pain can cause what we refer to as a paralytic or non-obstruct ileus. So if the patient's on some sort of pain medication to get rid of the pain, the bowel stops. If the patient's just in pain, the bowel can stop, right? So it affects peristalsis. Body position, we already talked about that, and respiration as well. All right, so exposure times then in the esophagus need to be 1/10 of a second or less. The further it gets into the gastrointestinal system, motion is still an issue, but is not as much as what it is in the esophagus. All right, so 0.5 seconds. Radiation protection, collimation, lead shielding. Now it's controversial, so I'll just leave it at that. When to use extra shielding. So anytime you're doing lateral views, what you might want to do is it's not really shielding for the patient. This is just to clean up your image. If you're doing laterals, you might want to put that lead apron behind the patient to try to block some of the scatter radiation from hitting your image receptor, right? Just like on a lateral T-spine or L-spine, something like that. Okay. So optimum technique, KVP being the main thing there, is we want to use high KVP to limit the exposure to the patient and penetrate the barium. All right, so esophagus. We're going to do a couple of things here. One is the radiologist comes in. Most of the time, your esophagram is going to come with an upper GI. Could be just a straight esophagram, but most of the time it's going to be esophagram upper GI. So what you're going to do is the radiologist or the PA comes in and they have the patient drink and they're going to take some images. And those images might be enough, right? So they may see everything that they need to see on those images that they took under fluoroscopy. If not, they'll say routine overheads. So your routine overheads are going to be your AP or your PA. And then we're going to do an AP or PA oblique, and we're going to do a lateral as well. So the reason we say AP or PA typically is because when they fluoro, it's going to be PA. They may rotate, once they lay the patient down and they put the patient on her stomach, now they're shooting AP, right? When we do our overheads, it's going to be a PA oblique. Okay, because now we're using the overhead tube and the image receptor is inside the table. So, and then we'll do a lateral as well. So, evidence of proper collimation, we want to see from the lower neck to the top of the stomach. We want to see the esophagus completely filled, and we want to see penetration of the barium in as much as you can penetrate barium. All right, so on the AP or the PA, we're going to have superimposition over the thoracic vertebra. You're not going to see the vertebra all that well because the barium is so dense, you know, and that's why I say in as much as you can penetrate barium. If you've got a solid stream of barium that's, you know, any kind of thickness at all, you just don't see through it all that well. You can test this. You can go into clinicals, take you one of those jars of barium, put it on the table, x-ray it, fluoro it, whatever. You just don't see through it. It's just that dense. And then we don't want rotation of the patient. rotation of the patient is going to be the same as analysis of rotation for a chest x-ray. You look at the clavicles and where they look like they intersect with the vertebra. All right, so CR is going to be about T5, T6, and the top of the image receptor at the mouth, patient either prone or supine, and collimation is going to be about 12 by 17. You don't want to collimate in too tightly because, again, you've got that deviation, especially on the lower end. You don't want to collimate just like what you would on an APL T-spine, because you might clip the lower end of the esophagus. So it looks like that. Okay, so our oblique, most of the time your overhead is going to be a PA oblique drinking esophagus. That's probably going to be the most important view that we're going to do once the patient leaves, or once the radiologist leaves. So what we're going to do is we're going to oblique the patient into an RAO position. We're going to do RAO because it's just going to be easier for the patient. You ever lay on your back and try to drink something? Feel like you're drowning, right? So we're going to put the patient into an RAO position. They're going to be laying on their stomach and oblique the patient 35 to 40 degrees. And top of the image receptor is going to be 2 inches lateral to the mid-sagittal plane on the elevated side. And it's going to be the central ray, I think I said top of the image receptor. Central ray is going to be T5, T6. All right, so what you're going to do is you're going to get this patient into the position. You're going to give them a full cup of barium. Got to have a straw in this case. They're going to be laying on their stomach, obliqued up. Put their right hand behind, kind of down to their side. You're going to have a tendency to want to put it up like this, right? Because it's more comfortable. But the problem is, if you have the patient's hand up by their head, it's going to elevate their upper thorax, and you're going to get some pretty nasty distortion. So put it down to their side, oblique the patient up, give them a straw, put the cup into their left hand, put the straw in their mouth, and tell them don't drink yet. And you go, you center up everything, you do all that. And you go back to the control panel, you rotor up, and then you tell the patient, drink, 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 drink. And on about the 5th drink, you make your exposure. Okay, if you just tell the patient drink, they're going to take a sip. So what you want is that esophagus as full as possible, so you're just going to repeat drink, and then you're going to make your exposure. Okay, so for all of your views, be it AP oblique, or your lateral, you're going to do basically that same thing. You're going to have a patient drink as fast and as much as they can. So here's a little tip for you. Next time your department gets some barium in, every hospital I've ever worked in did this thing, and I never understood why. But every time you get some drinkable barium in, you'll get these straws that are, I don't really have anything that up here to compare it to, a little bit smaller than your pinky finger. They're huge, okay? So you can get a lot of barium through that straw. You can get a lot of iodinated contrast through that straw, right? And they take all those things, they throw them away, and then they get the bendy straws, okay? Now bendy straws are convenient for, kind of a patient like this. They can get it in their mouth a little bit easier. But anybody ever drank a Whataburger milkshake? You can collapse your skull trying to drink a Whataburger milkshake, right? You got to let it melt a little bit. So if you had a bigger straw, would it be easier to drink the Whataburger milkshake?
Yes.
The answer is yes. Okay. Same thing with the barium. It's going to be easier with that big fat straw. So before they throw those away, snag them, put them in your locker. It's a lot easier to get the esophagus full. It's a lot easier to get be it barium or the iodinated contrast into the back of the mouth, off of the tongue. The patient doesn't taste it nearly as much. It's better for the patient, it's better for you, better for the exam. Get some of those straws next time you see an order come in. Anybody seen those things? No, you haven't. Why? Because it's thrown away. Ah, yeah. All right, so that's what your RAO drinking esophagus should look like. Again, don't over collimate. I'm a collimation nerd. I love collimation. Tighter, the tighter the better. But this is one of those exceptions where you really just should not try to get as close as possible. 12 inches, adequate. So lateral esophagus, nothing really new here except for the patient's to be in a lateral position, lateral projection, mid-coronal plane is going to be perpendicular to the image receptor, parallel to the central ray. Arms out in front of the patient. Be specific in your instructions. You just had the patient with the arm down to their side. It's natural that you might roll them up onto their side and they think, I gotta keep this arm down like this, right? Well, if you do, you're gonna have an arm over your esophagus, so make sure that you tell them to put your arms out in front of you. Most of the time, you can tell them to put them out like you're praying, right? And they kind of know what you're talking about. But centering is the same. All your centering on this was the same spot, T5, T6. Just center, in this case, the mid-coronal plane. What you should be working on here mentally in this semester is trying to kind of understand where the anatomy is within what you see, right? So you're looking at thoracic cavity, and you're thinking, okay, center to the middle, right? If you center to the center of the thoracic cavity, where's the esophagus? If this is the front, this is the back, where's the esophagus? Closer this way, right? So your centering then is going to be to the not to the mid-coronal plane, but more to the mid-axillary plane. Kind of like what you would do for a lateral T-spine, very similar. Okay, should look like that. Could have got a little bit better. The arms are, could have been elevated a little bit better, remove some of the soft tissue, and get a little better visualization of the upper portion of the esophagus. So pathologies, we've got a number of them. Zinker's diverticulum is a specific diverticula that you're going to see all the way up at the top of the esophagus. So you see where the esophagus comes through the superior thoracic aperture, right? It punches into the thorax. You see a great big collection of barium right below that first rib. That's a Zinker's diverticulum, okay? So esophageal web is usually going to be in the upper esophagus, and the statistics on that are really pretty specific. And it's usually long-time smoking asthenic women, okay? So, and they may be precancerous. Cancer will present in a lot of cases with what we refer to as a shelf sign, and that's just a protrusion, relatively flat protrusion. Achalasia is what we refer to as tertiary contraction. So what that means is, again, your peristalsis should be where the entire thing kind of squeezes around and pushes the food down, right? Where tertiary contractions are is that where one side of the esophagus is relaxing, the other side is pushing in, okay? So instead of going like this and pushing the food down, it's not. It's just, they're out of sync, right? So they're not synced up. Esophageal varices or varicose veins in the esophagus. And what those are, they present with a couple of different appearances. One is what we refer to as worm tracing. So you've seen where slugs crawl across your sidewalk and they leave that specific little trail, right? So what you'll see then are these stripes. Instead of the esophagus being nice and full, you'll see these filling defects that look like stripes. Or they may be individual little bumps, and what they refer to that as is the rosary bead sign. So it's a It's like somebody pushed, in on the esophagus to create filling defects in a lot of different places. So what causes esophageal varices is typically liver damage, okay? Now, don't ask me why this manifests itself here, I don't know. But with the liver damage, what you get is a increased pressure, blood pressure, in the portal vein coming from the spleen. Okay, so portal vein hypertension. And that manifests itself. The liver can't process the blood as quickly as what it needs to, so you got that portal vein, increase in blood pressure in portal vein. And where that manifests itself is in the esophagus with esophageal varices. So patients with liver damage, that's the population there. Atresia, we already talked about that. That's incomplete esophagus and stenosis. We talked about that. That's usually caused by acid reflux. And what they'll call that, the esophagus is coming down nice and fat, and all of a sudden it tapers down to just a trickle. And what they refer to that as the rat tail sign, because it looks like rat tail. So there's your zinkers, esophageal web, cancer, achalasia is also referred to as corkscrew sign, and you can kind of see why. Esophageal varices, atresia, and then stenosis. Yeah, what you got?
There's quite a bit of pathology. Are we only going to need to know kind of what we just went over, or we should know most of it? Are we going back to it?
I would focus on what is in your lab packet.
Okay.
Yeah. Those are the most common ones that I've personally seen. Okay, so GI series is just a series for the stomach itself. So you may have a esophagram, upper GI. Very common to have both of those. So what we're going to do with the upper GI is we're going to do, your first image is going to be a scout. And a scout, anytime we do a scout, that's just to familiarize yourself with the patient's anatomy so that you can tell where everything is, right? So if the patient has had some sort of surgery that they didn't disclose to you, you're not surprised, right? So a scout is just going to be a KUB, and then we're going to do stomach images after the patient drinks. So the questions that you'll see on the test are going to be one of two things, okay? Your upper GI, as long as you're using barium, is going to be air contrast every time. So you got to have fizzies, got to have it. Might have the fizzies available if you're doing a esophagram. But definitely if you're doing a barium study of the stomach, you're going to have to have those CO2 tablets. So the questions are going to ask you, where is the barium and where is the air? Okay, so make sure you pay attention to the question itself. And really it's all about gravity, right? Because what's going to happen if you've got this thick barium and you've got air? Where's the air going to go? Up. And the barium's going to go down, right? So a working understanding of how the stomach is situated inside the patient's body is important, right? So the stomach is not just straight up and down like this. The upper portion of the stomach is posterior, okay? So if I lay the patient on the back, just flat on their back, and this really, is upper GI in about 5 minutes here. If I lay the patient flat on their back, where's the air going to be? Think about the different portions of the stomach. Okay, let's start with the barium. Patient's laying flat on their back. The top part, which we call the fundus, is posterior. I lay the patient flat on their back. Where's the barium going to be? The cardia and the fundus, right? So then where's the air going to be? Not in the fundus, right? So it's going to be in the body. Might have some in the pylorus, but mainly in the body, right? So our views, what we're going to talk about in our projections are going to be AP. We're going to do LPO. Okay, we're going to do lateral. We're going to do RAO, and we're going to do PA. All right, so let's just kind of walk through it real quick. AP we already talked about. The barium is going to be in the fundus, and the body's going to be full of air, right? So if my stomach is like this, and I turn into an LPO, where's the barium still going to be? The fundus, right? So I might have more barium. I probably will have more barium on the. I'm seeing the PowerPoint from next door, scrolling in the window. Okay, so I might have more barium on the greater curvature, right? More air on the lesser curvature, but for the most part, where the barium is going to be is still in the fundus. Okay, so I'll roll over onto my. It's going to be right lateral. Where's the barium going to be now? It's J-shaped.
Lesser curvature?
Okay, so we're going to have some more on the lesser curvature, less on the greater curvature. But where is the gravity going to pull it throughout the entire stomach? Pylorus. So pylorus, right. So right lateral, pylorus. RAO. Fundamentally, is there going to be a whole lot of difference between this and this? No. So where's the air going to be in this? Probably greater curvature, some in the fundus. PA, where's the air going to be? Fundus. And the body is going to be full of barium, right? So just think gravity, right? And think about the general position of the stomach within the abdominal cavity. Right? Where's the air going to be? Where is the barium going to be? All right, so we start with fluoro, have a patient drink, blah, 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 blah. Same things that we did before. Preparation. Okay, so preparation for all this stuff, but especially GI series all the way through the VE, is going to be NPO after midnight at minimum. They might have some additional things. I've worked in a hospital where the radiologist comes in, they see any feces, any gas, and they cancel the procedure. So in some hospitals they may have the patient take laxatives, enemas, completely clean the patient out, but the minimum is going to be NPO after midnight for all these. All right, so we already talked about contrast. Biphasic, all right, so just real briefly on biphasic. I mentioned the exam where you might put the NG tube into the patient. It goes all the way through the stomach into the duodenum. That's what we refer to as an enterocolitis. In enterocolitis, what we have is two different things, and these are really kind of messy procedures. But what we'll do is we'll take a solution of barium and a separate solution of methyl cellulose. And what they'll do is they'll put an NG tube into the patient or a Dobhoff or something into the patient. And what the radiologist will ask for is those two different solutions in whatever sequence they feel that they need them. So what you'll have is a number of syringes full of those two things. You may have a bucket with more of it in there so that you can suck it up into the syringe and hand them to them as they ask for them, okay? So what they'll do is they'll inject some barium, inject some methyl cellulose, inject some more barium, more methyl cellulose. And what it does is it gives you a really nice air contrast exam of not just the stomach, but more importantly, in this case, what we're looking for is the small intestine. You just don't see good air contrast to the small intestine without doing an enterocolitis. So you got that, and then double contrast, and we talked about that as well. Double contrast always shows the mucosa. Okay, so we talked about all that. I want to get to the imaging. images. Talked about all that. Oh, yeah. So your phase of respiration should be exhalation on all your abdominal images. And we'll talk about, if we have time, we'll talk about that next week. But a lot of your hospitals and a lot of your doctors are asking for abdominal images on inhalation. But we'll talk about that this semester. All right, so here we go. So PA of the stomach. PA of the stomach, again, the fundus is up. And we can see the air in the fundus of the stomach. And we've got the body and some in the pylorus. Okay, so our oblique, again, we're going to angle the patient 40 to 70 degrees. We're going to off-center intentionally towards the elevated side. And our contrast should be in the pylorus and the duodenum. So our PA oblique is going to, this is a test question, so don't miss this, demonstrates pylorus and duodenum in patients who are more sthenic. So your hypersthenic patients, the pylorus and duodenum is going to be better demonstrated in the lateral. So this is your PA oblique. You can tell because the ribs kind of look like they disappear into the vertebrae. So they should be coming out just a little bit. So what we've got is air in the fundus of the stomach, and then we've got contrast in the pylorus and duodenum. LPO, again, it's an oblique. How you're going to tell the difference between LPO and RAO is where is the barium. LPO, it's going to be in the fundus, and RAO is going to be in the pylorus. And right lateral, so how you're going to tell the difference between right lateral and RAO? Look at the vertebra. The vertebra looks nice and square like that. That's your lateral. Again, we've got the distal portion of the stomach, the pylorus, and the duodenum. Okay, there is one other view that didn't make it into the PowerPoints. It should be in your textbook. It's a PA axial. You see PA axial in your book? Is it? Yeah. Okay. So the things you need to know about the PA axial, offhand, I don't remember the angulation. Is it 25, 30 degrees? 35 degrees. Yeah. So what you need to know about that is that in a hypersthenic patient with a transverse stomach, that opens up the stomach a little bit so that you can see a little bit better. So that's going to be specific to one population. That is going to be hypersthenic patients. Okay, so PA axial only applies to hypersthenic patients to open up the transverse stomach. Okay. All right. So what's our time? We're out of time. Okay. Any questions?